Good morning once again. So I would want to tell that GATT 360 degree is the most effective MIGS today. With all the discussion of why MIGS, because of the complications of trap, the problems with implants, we have a lot of advantages of MIGS that has already been discussed. And today I would like to tell the Schlemm canal opening surgeries like GATT and KDB. Various indications, especially open angle, both primary and secondary, post failed filtration surgeries, and nowadays even in angle closure glaucoma. Main contraindications basically are new vessels, anticoagulants, and bleeding disorders. Others are all relative contraindications. So coming to GATT, it was described by Dr. Grover, minimally invasive, 360-degree trabeculotomy, and we can use sutures or illuminated microcatheters, and we've been using the cost-effective umbrella-tipped 50-prolene suture, which is very easily made with the help of a heated metal object. So this is a GATT in a patient who has had a failed AGV because of the hypertensive phase. After the cataract surgery, so this is the incision over the Schlemm canal, and the 50-prolene suture with the umbrella tip is passed into the angle, and it is threaded into the Schlemm canal and gradually progressed. And then at the end of surgery, we see that the other end is visualized, and we pull both the ends, and 360-degree trabeculotomy is completed. The challenges are the bleeding, both intraoperatively as well as postoperatively, and can have false passages in the early career. The routine postoperative follow-up and the care as of cataract surgery, and we can see a trabecular shelf in successful GATTs. So this is one of a study which has got good results after failed trap also. Though the complications are there, but they are transient and managed medically, most of them. So KDB, because the doctor will be talking about it, I will not go into the details. So to compare between GATT and KDB, one is the degrees of treatment. I think many of us like elephants here, so we have put the elephant picture. So definitely it has a wider approach, and GATT and KDB has around 90 to 120. Head-on comparative studies have found three, where GATT is being compared with KDB goniotomy. One is in JOAG. We can see both IOP reduction as well as AGM reduction is better with GATT compared to KDB, and also the success rates. This is another study in uveitic glaucoma. This is the same study where it says that reduction of IOP and the complications are comparable. Another study in steroid-induced and uveitic glaucoma 2-year outcomes. Here also we can see that GATT outcomes with IOP as well as AGM reduction is better, and also the survival rates are better with GATT compared to goniotomy. The next is the cost. Definitely KDB is costlier, which can be afforded by only richer patients, and GATT can be done in all kinds of socioeconomic background. Yes, bang is there, but the outcomes of bang or the surgery is little ragged edges it causes. And the learning curve, if we have good visibility, I feel it's not a rocket science to learn GATT, and we do have a faster learning curve for GATT. So to conclude, I would say that GATT 360 is better in both terms of both IOP control as well as AGM reduction. And now with experience, we know that MIGS is not only for AGM reduction, it does reduce IOP even in preoperative higher IOP patients also. Thank you.
Thank you, Dr. Rashmi.